Thank you. So joining the session this evening, we're going to have a mix of clinicians, commissioners, policymakers, and some providers too, some of whom will be sitting quite closely to the national programme, but many of whom are joining this session for what would have been their National Optical Conference. And just to say that the NOC has been moved into next year. We're going to hold it in April, date yet to be confirmed, but this is really in the hope that we're going to be able to hold that conference face to face and create that networking opportunity for LOCs in a more traditional environment without too many restrictions. So fingers crossed for that. And so because some people are going to be quite new to the programme, we're going to start with an introduction to the national programme. I'll then move on and introduce the Optometry First clinical care model before we consider a couple of the key enablers to support the delivery of Optometry First. And the enablers that we're going to cover this evening are going to be commissioning and workforce. And of course, there are other key enablers that we could cover, such as IT connectivity, but we won't have time on this session to cover them. So following all the presentations, I do hope that we're going to have time to cover off some of the questions this evening. And like I say, please do put your questions in the chat as we go along. But if we don't have time at the end of the session, we will certainly provide a Q&A document when we put the slides, make this session available on the iCare Hub. OK, so to begin the session, I have the great pleasure to introduce our National Eye Care Recovery and Transformation Programme Director, Gloria Onwubiko. Gloria, over to you.
Thank you very much, Zoe, and hello everyone. I'm delighted that you could join us this evening. So thank you for giving up some of your time. My name is Gloria Onwubiko and I'm the Programme Director for the National Eye Care Recovery and Transformation Programme. The National Eye Care Recovery and Transformation Programme brings together teams across NHS England, NHS Improvement, NHS X, and NHS Digital. The whole idea of bringing all of these teams together, these national organisations together, is to support delivery of immediate elective recovery priorities and also longer-term transformational changes. And just to say that as a programme team, we work in alignment with existing eye care work that is already underway across organisations and national teams like Getting It Right First Time, the National Outpatient Transformation Programme. We work closely with the Royal College of Ophthalmologists and the College of Optometrists, the major eye charities such as the RNIB. And we work collectively with all of these organisations to deliver a comprehensive approach to whole pathway improvement and transformation. And just to go into a little bit more detail briefly in terms of what we do as a programme, our vision and our priorities. Could we go on to the next slide, please, Mary? Thank you. So, as a programme, our vision is to deliver rapid, high-impact improvements and support a sustainable future for eye care across the whole of England, and working with systems to increase productivity and ensure safety by trialling and evaluating new technologically enabled ways of working. And in our programme, we have a number of principles that underpin what we do, and that the first thing is to say that it is clinically driven, and we also rely very much on co-production. We work closely with patients, with professionals. We look at what matters most locally, because we have to take into context, how each region and systems, operate, and based on also their local population health needs. We are, I would like to say that a big focus of what we're also doing as a programme is to ensure that coordination and collaboration of all stakeholders. So it's great to have you here with us this evening. We have a number of priorities and objectives, which I'm going to go through in a little bit more detail on the next slide, please, Mary. So for this year, 21-22, we've set out a number of key program priorities that we would like to achieve. And we will be doing this in collaboration with all of the programs and organizations that I mentioned earlier. And our main priority areas is around, supporting systems and regions on the recovery and transformation of eye care services, with a particular focus on setting up, high volume surgical pathways, looking at what we can do within the outpatient space, so high flow clinics and outpatient procedures, ensuring that we have, robust risk management in place. And a key focus of the work that we're also doing is around standardized integrated care pathways. And this is across all of the subspecialties, so cataracts, medical retina, glaucoma, and including the work that we're doing within primary, secondary, community and independent sector care services. And this is also ensuring that we have primary care as a core part of what we're doing, and ensuring, that first contact practitioners and a way of managing low risk patients in the community. And if we could move on to the next slide, please, Mary, thank you. I'm not going to go into too much detail on this slide. I appreciate it's small, so you might not be able to read them. But this is just to give you an idea of some of our work streams and objectives. We have a number of work streams. Recovery, I mentioned earlier, which is particularly focusing on in-year impact on elective recovery, and looking at how we can shift activity or create capacity in other care settings, so that way we can release capacity, particularly within the acute settings, for patients who are more clinically urgent. Then we have our transformation work stream, and within this work stream, we are looking at digitally enabled alternative service models, essentially, is what we're looking at to trial within this team. And then we have our enablers group, which is made up of commissioning, workforce optimization, and data and analytics. You'll be hearing a bit from colleagues on the call later with regards to some of these areas that I've mentioned. But I just thought it would be helpful just to give people on the call just some context with regards to the program and what we've set out to achieve for this year and end of March next year. And I will stop there for now. Thank you very much, and I will pass on back to Zoe.
Thank you very much, Gloria. That's an excellent introduction to the work of the national programme. As I started the session, I recognised that many people who had the cameras on that I did fail to introduce myself, actually. So I'll do that now before I introduce the next presentation. So I'm Zoe Richmond. I'm an optometrist. I'm clinical director for the LOCSU support unit, but I also have the pleasure of working very closely with National Eye Care Recovery and Transformation small programme team as their optometry support lead. Next slide, please, Mary. So what is Optometry First? An Optometry First service covers primary eye care's contribution to both the recovery and transformation of eye care services in England. Primary care has kept going through the pandemic. We've delivered essential site testing as well as urgent and emergency care locally, avoiding the need for patients to travel to the hospital eye service. We've been both agile and responsive, and our practices, I believe, are now very well placed to support secondary care recovery, working together to ensure that our patients see the right person in the right place at the right time. Utilising the existing infrastructure and the primary care optometric workforce, and by that I mean optometrists, dispensing opticians, contact lens opticians, optometrists with higher qualifications, including those with independent prescribing rights, and the whole of the practice team. The Optometry First model can deliver a top of the licence benefit for our patients and enhance care with a reduced reliance on the hospital eye service. The overall aim of Optometry First is obviously to release capacity within the hospital. In turn, this will allow for the hospital teams to see those patients who are most in need. But Optometry First is also about improving the patient flow and experience and delivering care in a more sustainable model locally, making better use of what's available to us. So Optometry First makes best use of the core skills and clinical decision-making capabilities that already exist in primary eye care. The service will obviously be further enhanced where local connectivity allows for ophthalmology advice and guidance and the transfer of clinical data, and that includes patient images or full volume OCTs to allow for virtual review. And this avoids duplication of care, but it also allows for the clinical co-management of patients where that's appropriate to do. So I believe when an Optometry First service is implemented fully, Optometry First should really break down the walls between primary and secondary care. Next slide, please, Mary. So the care pathway is broken down into three parts largely. What's done pre-hospital, what's delivered in hospital, and what's delivered after diagnosis and out of hospital, post-hospital. Fairly obviously, Optometry First delivery sits in pre-hospital and also in post-hospital. But the work that we do in Optometry First model also influences what happens in hospital, and it only really works if delivered in a fully integrated service model. Optometry First is a model framework for a single comprehensive service made up of the already well-established care pathways, but it needs to be delivered more flexibly and not restricted by those individual care pathways. The care pathways should be allowed to interact, if you like. I've pulled this straight from the Eye Care Hub, and a lot of these subheadings will be familiar to people on the call, but I'm just going to pull out a couple of them. Direct referral, for instance. It's absolute nonsense to me that optometry are still having to refer via general practice. They're essentially duplicating the admin burden and adding to the pressure in general practice. In some cases, the patient is still invited to see their GP to make that referral decision. Optometry First recommends that direct referral processes are implemented locally. Optometry First also provides for referral filtering or referral refinement, if you like, covering the high volume clinical areas such as glaucoma, maculopathy, cataract. And this essentially optimises that first contact care appointment to deliver case finding, referral filtering, shared decision making, assessment and full management of low complexity care. And if hospital intervention is needed, more specialist care is needed, more fully informed referrals out to the hospital eye service. But we shouldn't forget the other care pathways. There are too many people with learning disability that have to go into the hospital eye service to receive their routine assessments and sight test because there's no local provision. And also children who fail their school vision screening are sent to the specialist hospital. Ideally, we need to be validating the findings following a school vision screening assessment in primary care initially. Evidence shows that when we do this, we can reduce the referral activity along that care pathway by 90%. I'm not going to cover off all of these areas, so if we can move on to the next slide, please. Thank you. So Optometry First also covers the long-term management. Optometry First provides continuity of care for people with a long-term condition. People with a diagnosis can be transferred back to their primary care professional for management and monitoring. This will mainly be those patients that have a relatively stable condition, who are low risk of sight loss and unlikely to require specialist intervention. Alternatively, some areas are looking at a diagnostic request service. Now, diagnostic request service is where the hospital invites a patient to go into the primary care setting for a set of diagnostic tests. So for glaucoma, for example, that might be to have a GAT reading disc images and visual fields. And that data is provided to secondary care. Secondary care colleagues provide a virtual review and clinical decision making and support for the patient remotely. So it streamlines that patient's care pathway, and it's something that we could put in place quite quickly as we start building an Optometry First service. Moving to the next slide, please, Mary. So I added this table in because I think it's a good visual aid, because you can see that how we can build an Optometry First service using the different component parts. Almost all systems and CCGs already have some sort of service in place working alongside primary care optometry. Optometry First isn't disruptive. It's supposed to be building upon what already exists, but pulling together the existing extended primary care services into a single comprehensive service and building on it. I think something I would like to say is that we don't talk about success in eye care enough. We concentrate on sightless and the growing waiting list. And I was in a conversation today, and that with the conversation was, well, they're doing so much better in Scotland, doing so much better in Wales and all the rest of it. We have pockets of excellence in England, and we're doing a really good job in some areas. And I'm going to just talk about the sight test for a minute. Sight test is healthcare success, isn't it? Through this service, we correct sight on a daily basis. We provide case finding, early intervention, and support the prevention of sight loss. But we also take it for granted. I put my glasses on in the morning, and if I take my glasses off again, I can't see any view. I am, disabled. We shouldn't take this for granted. We need to build on that successful service. And I think it's important to have, when you're looking at an Optometry First service, to consider what can be done with the existing workforce, with the existing practices, and the optometry. There's elements of Optometry First, so all that section in green can be provided as first contact care, synchronous with the sight test. And so because of that, I believe that all practices should be invited to participate in those services and have the opportunity to do so. We also have the advanced care pathways. Now, not all practices will be interested or have the capability of delivering these services. And these services are going to be restricted by practice participation based on the skill and capability and the equipment in practice. So moving to the next slide, please, Mary. So building your Optometry First service. These are the initial steps. First of all, contact your LOC. Now, people on the call say, well, she's obviously going to say that. She's the clinical director of LOCSU, and she's going to say, get in touch with your LOC. But seriously, the LOC is a representative body for all primary care optometry, all the practices and the professionals working within a locality, and it is recognised as such by the NHS. Working across the country, where you see good examples of where good services have been put in place with primary care and secondary care and everybody working well together and integrating their service models, it's because it's built on good relationships and good engagement. Unfortunately, there are still areas where there is little or no engagement with the LOC or primary care optometry. And so I genuinely believe for some areas, this is the place to start. Moving on from there, the next thing to do is to optimise your existing locally commissioned extended care pathways. As I said before, Optometry First builds on those existing pathways and brings them together into a comprehensive service model. But we first need to understand whether or not your existing pathways are delivering optimal outcomes. And I'm going to use glaucoma repeat readings as the example here. We know that glaucoma repeat reading service or glaucoma repeat measure service, whatever you want to call it, delivers good outcomes. It delivers optimal outcomes for that patient if they're presenting to a participating practice. But glaucoma repeat readings doesn't deliver optimally to the entire population, because what happens to that patient that doesn't present to that participating practice, or what happens to that patient that chooses to have their sight test, when they're visiting their family member in a different county? That patient doesn't realise that they've opted out of their locally commissioned service when they make that journey and they choose to have their sight test in a different place. But what we do know is that a repeat reading service commissioned in isolation won't deliver optimal outcomes for the entire population. But if it's commissioned alongside an enhanced case finding service, that will deliver optimal outcomes. Enhanced case finding is a relatively new term, but it's been around for years. There are services that have been delivering the clinical workup that's described in enhanced case finding for many years already, and I'm going to signpost to the Manchester GERS service as an example of that. So we have most CCGs in the area already have a commissioned repeat measures service. Only 11 CCGs have an enhanced case finding service. So there's a huge opportunity to make more optimal use of your existing contracts today and get an in-year benefit as a result. Working through the next steps, understand your workforce capability. I'm not going to touch on that because we're going to have a presentation in a moment around workforce. But then use the Optometry First toolkit that's available to you on the iCare Hub to identify the gaps in your local provision and understand what it is that your local system may benefit most from next. And also I'd invite you to get in touch with the National Eye Care Recovery and Transformation Programme team. We have a team of operational implementation leads who will be very happy to discuss any challenges or blockers to implementation that you might have come across. Next slide, please. So that was the clinical model, and now I want to move on to one of the enablers and invite James Lorigan. James Lorigan is commissioning workstream lead for the National Eye Care Recovery and Transformation Programme. Over to you, James.
Brilliant. Thank you, Zoe. Hello, everybody. I'm going to immediately say that there is a strong possibility that I'll be invaded by small people during this, so apologies if that happens. Next slide, please. So what I'm going to talk about a little bit about through this is one, kind of explaining a bit about what commissioning is, where it's going at the moment, a little bit about what that means for eye care commission, what we believe that means for eye care commissioning at the moment, and that's kind of a moving feast. A bit about the kind of the challenge, and then kind of where we think that Optometry First fits into this. So this is a pretty standard definition of commissioning, and this is kind of from the NHS England website. Commissioning is a process of assessing needs, planning and prioritising, purchasing and monitoring health services to get the best outcomes. And you'll recognise below that, many of you will recognise the old kind of world-class commissioning wheel. If you move on to the next, I made a mistake of adding animation to this thing. There we go. So actually what's changing? In many ways, the definition isn't changing that much. The definition will remain the same. But really, we're moving from a world in which the NHS is organised around kind of the principles of competition to a world in which the NHS is organised around the principles of collaboration. Because there will be collaboration within systems. So effectively, you have a population of X number of people, so about 1 million people, and you have all the resources will be held within that system, and they'll be expected to kind of to build relationships between NHS providers, the CCG, and local authorities and other kind of statutory and voluntary sector bodies operating within that. So it's how do we stop trying to use market mechanisms, stop trying to kind of transactional mechanisms to try and drive up healthcare, and really get people to work together to try and tackle really complicated issues. So again, the commissioner provider split's going to go. There's going to be a collaborative model. The idea of having this individual provider commissioning, contracting mechanisms set up, and individual providers being performance managed on effectively volume of activity is going to shift away. And it's going to be strategic commissioning based around kind of population health. How do we start to pursue outcomes, and how do we start to focus on making sure that the population gets better rather than we do a particular procedure really, really well in the most efficient way possible. I think kind of one of the other big changes is that actually funding is going to start shifting down to integrated care boards, and I'll talk a little bit about that in a second. Can we move on again, please? So what is staying the same? and actually one of the things that kind of potentially offers the greatest tension, but is obviously actually something to be defended kind of at all costs here, is patient choice. Patients will still have the choice of the hospitals they go to, the service providers they get those services from, and that is will remain in the legislation going forwards. NHS trusts will remain as statutory organisations, and again that potentially creates some sort of tension between as we kind of move into this new model, and actually the role of the independent sector. So with patient choice, you still effectively need to have the ability to buy different services or send patients to different places. And actually, as COVID has demonstrated, the independent sector is kind of vital to the delivery of services going forward. We do need that additional capacity within the NHS. And so it's likely that there will remain some elements of competition that will remain. So this isn't a complete shift to a collaborative model. There will be elements of competition that are likely to remain. Can we move to the next slide, please? So what does it mean for eye care? So in about 2018-19, we spent £2.9 billion on eye care services. That money was spent predominantly by CCGs, about 70% by CCGs, about 20% was spent under the General Optometric Services contract, and then the remaining 10% was split between specialised commissioning for kind of a small amount of activity and public health commissioning for, again, a fairly small amount of activity. And actually, the problem by having 4 different commissioning services on the pathways, you start to kind of create a whole series of perverse outcomes, kind of a series of distortions. So what is going to happen going forward is that effectively the money will move to the integrated care boards. However, NHS England will remain maintain kind of the specification and national negotiation of and design of kind of the contracts for specialised commissioning, the GOS contract and public health commissioning. But effectively, the integrated care boards will be expected to purchase that and build that into their larger contracts for services. So actually, that kind of gives an opportunity for integrated care boards to think differently about how they use that money in one go. And so effectively, that means, so on average, there's about £55–60 million spent on eye care per ICS. So actually, that's a real amount of money that can be used in a kind of strategic way to invest in services. Next slide, please. So this is quite a wordy slide, but broadly, there is quite a substantial challenge that we're facing. In 2019, before COVID, eye care services were in a fairly difficult place. We had 22 people per month were going blind, had quite a large waiting list already. It's the highest volume specialty, so 8 million outpatient appointments and about 500,000 surgical procedures per year. And there's kind of a problem of eye care spend was growing faster than the budget. So actually eye care spends about 5.5% during that period, with the budget was growing about 3%. And activity growth was about 2.5%. So you see that actually eye care spend is growing fairly quickly, and we know that this is a problematic thing. So really, and then obviously COVID has now hit, and we are in a place where actually ophthalmology makes up 10% of the RTT waiting list. And this is going to cause us some problems for some time yet as we try and work through these issues. So really, we've got kind of 2 major challenges that we have to address at the moment. One, which is how do we recover? And actually, going back to 2019 is not an option. We need to transform as well. Where do we want to go? And we also have to do it within the context that there is a transformation of services taking place, or transformation of kind of the organising principles of the NHS taking place at the moment. So really commissioners need to start to kind of align system and place strategies, actually how we start to make sure we spend that 55-60 million pounds per ICS in a better way, make sure that all the contracting and procurement starts to complement each other rather than kind of thinking of these things as separate pieces, and start to take advantage of kind of the real digital technological opportunities that are coming ahead of us. So ultimately this is to kind of effectively, we need to do two things. We need to kind of stop avoidable sight loss, and we need to bring the cost growth under control to make sure that we have a sustainable service going forwards. Next slide, please. So kind of really as a national programme, we have a set of bets that we can make in order to kind of to not just recover services, but also to start that process of transformation. And really we've got to kind of, one, try and reduce the flow of activity coming into hospital in the first place, slow that flow, allow and make sure that we can see those patients who are at highest need of kind of ophthalmological care to be seen by ophthalmologists. We need to improve the productivity on the pathways, and I think obviously that's been the mantra for the past decade about kind of driving efficiency, productivity, all the thing. But without being able to drive productivity, we aren't going to be able to recover these services. We have to increase capacity in other settings. We actually have to look at how we can use the total optical workforce to deliver care in a different way. And so we need to have a think about what we can do with optometrists. We need to have a think about what we can do with community diagnostic hubs. And the final bit is we really need to think about how we deliver that care differently. There is an incredible opportunity for digital transformation within eye care, and we need to think about how we can really start to use that. And actually a lot of that work is going on already. And then onto the kind of the final slide. So in terms of kind of optometry and what we're doing, we've got really two big pieces of work. Firstly, how can we start to maximise what we've already got in primary care contracts, and what can we do in year? Can we rapidly start to map out what's going on within the contracts, where there's an opportunities to kind of deliver more activity using the existing contracts, start benchmarking, kind of pricing, service specs, all that kind of stuff, and start to really sort of make sure we understand what opportunities are there. And then kind of the second part is around optometry first. We need to give this, we need to test this. We need to make sure that this is a model that we can get to work properly. So we want to find 2 to 3 integrated care systems to test it with. And we want to find systems that are probably in slightly different places. So one who's nearly there, got almost everything in place. One which is somewhere in the middle. And one which is at the start of the journey with very little in place in terms of optometry, and work out how each of those different systems will get to a similar place. Do we need to do this softly, introduce it piece by piece, or can we almost go to a big bang and just move to an optometry first model? And then I think we really need to start to kind of work through what the blockers and enablers are. So kind of local commissioning approaches, going to be one of them, all the stuff around workforce, transfer of images, all the many other kind of problems that are going to come up. How do we start to identify these, work through these, and provide kind of the tools, the case studies and the guidance to overcome them? Give this the best chance it possibly can. Okay, that's all for me. Thank you.
Thank you, James. And we've got lots of comments in the chat. Keep them coming in, and don't forget to bring your questions in there too. Moving on to our workforce now, which is another key enabler, and we're joined by a number of experts from experts in workforce and people from working within the national programme. So I'm going to introduce the whole team at once. So Anthony Garrett is the Senior Clinical Workforce Optimisation Lead for the National Programme. Joining Anthony, we have Daniel Hardiman-McCartney, who is Clinical Advisor to the College of Optometrists, and also Stuart Pell, who is one of ABDO's Clinical Lead team. So Anthony, if I can hand over to you.
Thank you, Zoe. Can we go to the next slide? Oh, maybe this is starting with Daniel. Are you okay to start, Daniel?
I can start, that's fine. Good evening, everyone. Thank you for joining. I'll be short and sweet even. I really want to start by saying Optometry has a long history as a partner with the NHS. But I want to start at the beginning. You know, what is an optometrist? And I know many of the people on the call tonight are optometrists or are very closely involved with eye care delivery, so we know this. But there are other people on the call, commissioners, people as part of local systems, who may not realise, you know, what an optometrist is and what an optometrist does. So first of all, I just want to make clear an optometrist is a highly skilled, independent professional. They're registered independently, so they're not an allied member of healthcare. They're an independent profession in their own right, registered by the GOC. They're educated for 3 years, and they all undergo a 1-year robust training assessment with OSCE assessments at the end. And at the end of it, there's lots of opportunities. There's a big myriad of options, from independent prescribing, glaucoma qualifications, but actually the core qualified optometrist is highly skilled as well, and that's something I want to talk about. Mary, next slide, please. Optometrists in numbers. So there's a lot of optometrists distributed across the UK. There's about 14,500 registered in England. Of those, there's about 500 full-time equivalents working within secondary care. There's about 600 independent prescribing optometrists, and a lot more in the pipeline once we can open up placements to enable them to be fully registered. And then of those as well, lots of them taking additional qualifications and training placements to develop specialities in glaucoma, in medical retina, in pediatrics, and in contact lenses. Mary, next slide, please. So this really is, I guess, an opportunity in a decade to have this much focus and attention from the highest level within NHS England to really look at eye care and commissioning, an opportunity to level up the playing field, and from our perspective, an opportunity to enable the joint vision of the Royal College of Ophthalmologists and the College of Optometrists, and that's to develop safe and sustainable eye care for every citizen in England. But back to basics, translation. We know a lot of local systems struggle with understanding what an optometrist does, their skills, what they can do at core competency, what the different qualifications mean, and how that translates into pathways. And so the workforce, which has been led by Anthony, Carrie and Alex, the LOCSU, AAP, College of Optometrists and ABDO have supported them to develop a very simple matrix, how to enable local systems to understand what an optometrist can do. Mary, next slide, please. So I don't expect you to go through this in detail, but I do hope that every one of you on the call tonight has registered on the NHS Futures platform, where there's a wealth of information and discussions taking place about this. And one of the things on there is this matrix, which is a very straightforward grid. And it's not just for optometry, in fact, it's for optotists, ophthalmic nurses, dispensing opticians, and it sets out what a core competent optometrist can do, so that's every optometrist can do, and also what optometrists with further training can do, and also what the opportunity in areas of the country where there are independent prescribing optometrists, how that can even further enhance pathways. Next slide, please, Mary. So just an example of the grid here for glaucoma. If you look at the grid quite carefully, optometrists can do quite a lot without any additional training, just at point of registration. And it's a really untapped resource and a real postcode lottery at the moment across England. And that really has to change. It's a real missed opportunity for the parts of the country that are not currently utilising their core competence optometrists, let alone their optometrists with additional skills and training. Next slide, please, Mary. And so final slide. The workforce is one piece of this, and all optometrists on this call will know the potential for optometrists. But what we need to do is we need to translate that now to local commissioners and local systems and join it up with the commissioning and connectivity, and also ensure that we get access to patients to ensure we can support the services, to support secondary care, but not just go into secondary care and just help out here and there. We need a sustainable change to eye care delivery in order to ensure we can maintain our competence and help ensure that members of the public see their optometrist not just as a point for spectacles, not just as a point for triage, but a point that they can go to for management, for treatment, their one-stop shop for eye care. And this fits into the optometry first narrative, where there's the three parts of the pathway: the initial, the middle, and as Zoe absolutely described, this joined up approach where we breaking down titles. It's not about the title of what professional you are, it's not about where you are, it's about an integrated system all working together to save sight. And there's never been a bigger challenge than there has been now, with so many people waiting for not just elective and cataract procedures, a lot in the news, but actually those long-term care, those glaucoma follow-ups, where people who were relatively low risk a year ago are ceasing to be low risk, and they need to be seen in the here and the now. Thank you very much. I'm now going to pass on to Stuart Pell at Abdo.
Thank you, Daniel, and hello, everybody. Very much as Daniel just said, we are aware that there are many dispensing opticians and optometrists on the call this evening, but I'm just going to give you a rundown of a dispensing optician and how we fit into the integrated primary eye care sector. So if you can move on to the next slide, please, Mary. So the dispensing opticians, so in the UK, there's currently over 6,500 qualified dispensing opticians registered with the General Optical Council. And our qualification route is by a 3-year distance learner or day release course led with a case record-led assessments and a period of working in practice. Or there's a 2-year full-time course at a GOC approved registered training institution, followed by a year in practice under supervision. So dispensing opticians, what do we do? How do we fit in? Well, we take the optometrist's prescription, we interpret it, we find the best spectacle lens for that prescription, the best spectacle frame. We're highly skilled in taking frame measurements, bespoke frames if required, and we know that we will fit those spectacles so that they are perfect first time and every time. So we are professionally skilled to provide fit-for-purpose medical devices. Another way we fit into the integrated primary eye care service is we're low vision experts. So we're qualified to do low vision consultations. We can sit down with a patient, discuss their needs, assess them, and fit them with a low vision appliance, and follow that through with future aftercares. We're also regulated. We can provide paediatric dispensing as a regulated function, and we can also, as a regulated function, dispense the partially sighted. Where we really come in, where we can really enhance our clinical skills and fit into this system, is our further qualifications. So going forward, we can become contact lens opticians. Once qualified as a contact lens optician, we can then become an enhanced services contact lens optician, or the dispensing optician can do an enhanced low vision honours course. Can you go on to the next slide, please, Mary? So our further qualifications, our further clinical qualifications, we can do a 1-year top-up course to become a contact lens optician. Now, these guys are really skilled in keratoconus fitting, rigid gas permeable lenses, astigmatism, multifocal contact lenses. But as part of this course, we also become experts in anterior eye complications. And again, that's where we can really fit into this integrated eye care. Once qualified as a contact lens optician, we can then become an extended services contact lens optician. Now, this is a further pathway where we take 11 WOPEC modules. Those WOPEC modules include red eye, flashes and floaters, AMD, dry eye and optometric practice, glaucoma and the optic disc, IOP, tonometry and visual fields. Once completed, we then take the WOPEC OSCE. And again, this is where we can really work with our optometrist colleagues in practice. So the extended services contact lens optician qualification really promotes the single service offer of integrated care within the primary care sector. So working in practice as part of a multidisciplinary team, we have a triage process in place which signposts the anterior eye complications to the MECS or CUES accredited ESCLO, the Extended Services Contact Lens optician, whilst the posterior complications can then go to the optometrists. Another area where dispensing opticians can really fit into this integrated eye care system is the Extended Services Contact Lens optician can undertake intraocular pressures and perform GAT as part of a delegated function with an optometrist on site. So I hope that's clear on our qualifications and our profession, and I'll hand you back over to Zoe. Thank you.
Oh, it's me, I think. Thank you, Zoe. Can we go to the next slide? So I'm working with Daniel and some of the colleagues and Zoe, obviously, and I work in NHS England Improvement, and we're working very closely with Health Education England and also various departments and teams within the NHS England Improvement, such as demand and capacity, and also the people team, so the HR function. And we're coming together to really look at that holistic workforce within eye care. And within the long-term NHS long-term plan, there's a commitment to evidence-based approaches to workforce planning and deployment. And I've seen a few comments in the chat around, do we have sufficient number of optometrists or this? And I think the real answer to a lot of this is we have a sense, but we don't really know. I think to really know what our workforce needs are, we need to take a competency-based approach to it, to understand the full skills and capabilities across the whole workforce. And I put some of the principled approaches of how we want to approach some of this, and some of it's around digital tools and looking at population health needs and some of those. And all of those things really need to be brought together. And what we're very keen to do is to push this notion of a competency-based approach and to develop some evidence base around that. And that's why what Daniel shared around some of those competency mapping is very critical. And if we go to the next slide, these are some of the areas of focus. So we're running a workshop on the 29th of November, and that's for anyone who wants to talk about workforce and help us prioritize and understand what people's needs are in this space. Some of that's around secondary care and looking at rostering and job planning, some of those digital tools, and how you operationalize the competency mapping document that Daniel shared earlier. Some of that's around career and educational pathways, mapping competencies across different groups. That might be technicians, it might be enhanced and advanced practitioner roles, or people with OPT. And it's looking at sustainability in all of these areas. So not just service delivery, but what kind of job is this, and where are the opportunities, and how do people access education, and some of those aspects. Now, the area that's probably most of interest for primary care is strategic workforce planning and redesign. And what we want to do is work very closely with the commissioning arm, so James, and population health, and understanding our workforce. So what's the supply pipeline within an ICS, for instance? Do we have good sight of our optometrists, within a system? What kind of data do we have on that, and how do we get that data? And to look at a dynamic model of that, so to test different scenarios, if you're upskilling certain staff or for other things, so that you really start getting a sense of that holistic view of the workforce. And so I think I'd very much encourage everyone to think system and go talk to their system, and I think that's really where a lot of these opportunities are. Come to our workshop on the 29th of November if you're available, and would really like to hear from people. The one last thing we're doing as well, and we can post all the links to HE support offer and the NHSEI support offer, is the CLEAR program, which is the HE Commission program, and we're looking at an ICS clinician-led ICS service and workforce redesign. So working with clinical teams on the ground, getting patient data and workforce data, and really looking at how we can optimize and design things around the needs within the workforce and patients themselves. So yeah, I think that's everything from me. Do come to our workshop. Let me know if you have any questions. I'll put my email in the chat, and happy to have a conversation with anyone. Thank you, Zoe.
Excellent. Thank you very much, Anthony, Daniel and Stuart. Please don't go anywhere. I do think we're going to be able to have a few moments for some questions at the end of the session. Can we have the next slide, please, Mary? Oh, the next slide, when Mary finds it, will be a promotional slide for the WOPEC LOCSU OCT interpretation module, which we're launching this evening. The module has been launched for what would have been our National Optical Conference. It's a long-awaited module available to all optometrists, targeted at those delivering maculopathy referral filtering and monitoring services, obviously, but it's also going to be very important for those practitioners that are working within urgent eye care services locally, so those delivering what are now termed as MECs or QS services. So more information will be made available to LOCs, and as usual you can get your codes to access this training material through your LOC. Okay, moving on. I think that's probably the last slide, Mary, is it? Yes, we're moving on to Q&A. So if we can stop sharing slides, if I can ask all those that presented today to put their cameras on, and also invite Richard Whittington, who's Chief Executive of LOCSU, who has been very actively monitoring the chat for us this evening. I think we've got about 6 minutes. Richard, to be able to come off some of the questions, so over to you.
Thanks, Zoe. Hi all. There's quite a lot of questions, so this is going to be a bit quick fire. But as Zoe said, we'll do a document at the end of this that tries to capture all of the questions that have been asked. So I'm going to start. There's been quite a lot of questions about commissioning, so I'm going to pose the first one to James. It's a question that came up quite early on, which is that it was expressed that there's a kind of fear that national transformation could be could lead to the dismantling of successful locally commissioned services, and whether or not there's any assurances available to say that that's not going to be the case. And also, leading from that, how do we assure ourselves that we can get these services commissioned within and properly funded within the new collaborative frameworks?
So taking the first part first, really, I think successful services can be built upon. I think, as I kind of try to set out, returning to 2019, or the idea of going to a world in which is entirely all eye care services driven through ophthalmologists and ophthalmology departments is just not sustainable. We have to have, if we are to overcome the challenges that we face now, and actually the challenges that we faced before COVID, we need to make the most of the entire optical workforce, and we need to be able to get systems to build upon kind of successful working relationships. And actually, I've seen Lee's comment in the thing, optometrists as partner in place, in a place-based partnership. This is entirely where we need to get to. The shift of the new commissioning arrangements is towards provider collaboratives, and that doesn't mean big hospitals collaborating together. That means all providers being able to collaborate together to work across pathways. So that, I think, is the key message that we have to build upon here. The second part about kind of securing funding, I think that's going to be the trickier bit. Ultimately, this is one of the bits that we are going to have to work together on. We're going to have to look at what we can do at a national level and what we can support systems to do at a local level. Although there is additional funding being put into the NHS for recovery funding, the NHS as a totality is going to be severely financially challenged over coming years. And so we have to work with systems to make sure they realise that actually not spending this money in a kind of coherent, strategic way is going to cost them a lot more money. And actually, I think we don't really have we don't fully account for the knock-on costs of poor eye care in a whole load of other things around social care and frailty, A&E, and a whole load of other places. So I think we need to make sure that we're kind of building that case, and that's kind of one of the things that we want to start doing around kind of the population health work, is to start building that case much more articulately, that actually good, coherent, sensible investment in the totality of eye care services is the only way to get spend under control and to improve patient outcomes.
Thanks, James. Right, one for Zoe next. I was going to ask you to discuss whether or not you thought repeat measures was wet and wimpy, but I'm not. I'm actually, there's a number of questions have been asked about whether or not there's a specification available for optometry first, and if there's not, if there's any kind of timescale for one.
Okay, so there are resources around Optometry First on the eye care hub, so there's a toolkit available there. So we are looking to develop more resources, but we also want to work with a small number of systems and co-develop those resources with those systems as we pilot Optometry First. So they will be coming. Our first priority really is to identify those systems to work with.
Thanks, Zoe. Next one for the workforce team. We heard a lot about workforce, and we've actually heard a lot about the workshop, which I think probably will answer this question, but it's a general question, which is, given the aims that we've heard about for the whole of the optometry workforce and for Optometry First, do you think we've got the numbers and the skills to be able to deliver it?
I'll go first. Yeah, absolutely. So we do have a population of highly skilled optometrists, dispensing opticians, orthoptists, utilising technicians both in primary and secondary care. So yes, there is a workforce. Do we have the skills? Yes, absolutely, we've got the skills to deliver it. The question is, will the NHS commit to funding and commissioning that equally across England to enable that to happen? And when you look, in the news last week, the numbers of people who are waiting for not just elective but routine follow-up care, the number of people who are losing their sight every week. We need to act in the here and the now. And there's really exciting things happening about digital transformation in the future and AI and technology and hubs, which are great, but they're further down the track. The best case 6 months, a year away. We need to do something now, and primary care can really do something and deliver something quickly in the here and now before end of the year.
Splendid, thanks, Daniel. And the final question, because we've got 1 minute left, and it's to Gloria, and it's also gives an opportunity for Gloria to wind this up. A number of the questions that were coming through were actually talking about the facilitation of trust between different parts of the eye care pathway, trust between different stakeholders within the commissioning of the pathway. What is it that the programme can do to help foster trust, both at a national but also crucially at a local level, so that we can actually get some of this commissioned without bogging ourselves down in maybe some of the discussions of the past?
Thank you for that question, Richard. I'm just going to try and briefly put my camera on before I get cut off. But just to say, in terms of trust, I think it is part of what we're doing right now, talking to people and collaborating and ensuring that we are engaging with all of our relevant stakeholders. And I think that is one way we buy trust, is by ensuring that whatever it is that we're doing as a program, we are transparent, we are inclusive, and that we continue to listen, and that what we come out with in terms of our outputs are tailored to local needs. So and I strongly would encourage everyone on this webinar tonight to get involved with the work that we're doing. If you're not already a member of the Eye Care Hub community, I would really encourage you to sign up. We would really value people's contribution and participation and engagement. So please spread the word out there. It is a partnership. There is a lot to do in this space. There's lots of work to do, and we will build trust by working together, and listening to each other and
coming up with solutions, together. So it's not just for the national program to fix this. We're going to do it together in partnership. Thank you.
Great. Thanks, Gloria. Zoe.
Thank you. That was we fitted in quite a few questions there. I was quite surprised, but it is now turned 8 o'clock and I don't want to take any more of your time. I would like to thank all of our speakers this evening and everybody for attending and joining in the conversation. We will continue this conversation on the iCare Hub. Have a lovely evening and thank you very much for your time. Bye.